We will get started. Dr. Conti is going to talk about the current situation of COVID and children. Dr. Conti is a team physician for a local soccer club, as well as a medical advisor to a local school district, and also the team physician for U.S. Soccer Federation for boys and girls under 14 to 17 for the national teams. So he's very well versed in COVID and kids, especially athletes. So he's going to give us kind of an update on the current environment, the different concerns in that age group, and then give us a little bit of an update on the status of vaccinations and where he sees things going. So I'm going to turn it over to him. If anybody has any questions, there is a Q&A on your bottom of your Zoom screen that you can put in a question, and then we'll get to those questions just as soon as Dr. Conti is done kind of giving us the lay of the land. So I'm going to turn it over to Dr. Conti.
Fantastic. Well, thank you, Betty. And it's great to see folks tuning in. I know everyone is suffering from some degree of COVID fatigue. It's been over a year now since we've been kind of living in this new reality. And, you know, we've had some ebbs and flows in terms of cases and all kinds of things. And now, you know, we seem to be kind of rounding this turn and seeing some light at the end of a very long and dark tunnel. But I wanted to take some time just to talk now as we are going into this period of time during the pandemic where we have vaccine access and kids are going back to school and the weather is getting warmer, just to talk a little bit about COVID specifically as it relates to our children and our teenagers, because they're a group that still are at risk because many of them, because they are under the age of 16 or under the age of 18, depending on the vaccine, are vaccine ineligible. So again, we're not going to spend a lot of time talking about the science of the virus. I think people have tuned in to news agencies and all kinds of other forum discussions to talk about that. But I want to just give us just as much recent data information as I can as it relates to children, because again, this is a fast growing group of COVID cases, not just here in Pennsylvania and Allegheny County, but nationwide. So as of this morning, there were 3.7 million cases of COVID diagnosed by testing in the United States. That does not include suspected COVID cases for which there was no confirmatory test. But 3.71 million is a lot when we consider that about a year ago, there were under 1,000 cases. The case rate at that time was around 0.5 cases per 100,000, and now we're up to 4,931 cases per 100,000 within that pediatric population. That is an incredibly exponential increase in the number of cases. And I want to say from the outset that we are not trying any kind of a scared straight tactic to terrify people about COVID in children, because the bulk of children, the large majority, still have mild symptoms, moderate at best. Many are asymptomatic, but the number of cases is rising. And although none of what we're really talking about is super specific to children, because we're seeing more cases in children, there's more data to be collected and crunched. And so we're seeing more evidence of some of these bad outcomes in children. The percentages have not changed, just the numbers, the raw numbers have changed. So out of that 3.7 million, about 74,000 or about 2% have been hospitalized. And there have been about 1,000 or so deaths out of that 3.7 million, which is about 0.03% of all cases in children aged 0 to 19. And although that doesn't seem like a large number, and it's not, it is a significant number if it's affecting you or your family personally. So this disease still can make children very sick. And children are ending up hospitalized in the ICU. And although it's a small number, some of those children are dying as a result of COVID-related issues. Here in Pennsylvania, as of today, we have 162,000 cases, less than 10 deaths in the state. So a very, very small number, and not a significantly large number of hospitalized children. Right now, our pediatric bed situation in Pennsylvania, we're at about 30% or so capacity for our pediatric ICU beds as it relates to COVID cases as well. So put this in perspective, now pediatric COVID cases are about 13% of the total number of cases in the United States, whereas they were less than 1% a year ago. They're rising at about 2 to 5% per week. And again, because kids are in school, the weather is warm, kids are playing sports, and many kids are not vaccinated, even though they may be living in household with fully vaccinated parents and older siblings. Those cases are rising. Specifically, we are seeing here in Pennsylvania and all of the surrounding states, we are seeing the UK variant as being the most prevalent variant strain, the most dominant variant strain in the population. And there, is laboratory-based testing. When they do the testing, they're able to identify the specific variants in most cases, even though that may not be reported to you, the patient, on the piece of paper that you get from the lab as it relates to your results. So we've got, growing numbers of children that are getting COVID. But if we look at just the larger picture, although the death rate curve seems to have plateaued and is starting a downward trend, the number of cases is still going up, albeit at a slower rate than it was previously. But there are still new COVID cases every single day. So that is simply to remind everyone that this is a transmissible virus that is still being transmitted among unvaccinated or non-fully vaccinated individuals, which is why we're seeing it in increased rates in children. So I figure I wanted to give you the numbers, then we can talk a little bit about the vaccine, and then very briefly talk about some of the specific complications and what that means for you as a parent or for your children or for your teenagers. So we know that we have 3 commercially available vaccines. 2 of them are mRNA platform vaccines that require 2 doses. It is called a prime boost schedule, where the first dose kind of revs up the immune system, wakes it up, gets it ready for this coronavirus by tricking the immune system into thinking that it is infected when in fact it's not. We are not being infected with the virus. We're not being infected with any elements of the virus. We are being what is being introduced into the body is the messenger RNA, or the blueprint or the recipe to tell the body to have its cells begin to resemble the coronavirus, so that our immune system then recognizes what it thinks is coronavirus, but is really human cells that are mimicking coronavirus. So that when we do see the real coronavirus, our immune system now has a point of reference and can mount an immune response. So whether it's the Pfizer vaccine, which is a 21-day interval, or the Moderna vaccine, which is a 28-day interval, the second dose is the same amount, the same concentration, but it's administered, and then that boosts our immune response. And then within 14 days of that second vaccination, we are considered fully vaccinated. And we're hearing more and more about what that means. And we can talk about that if that's something that the chat or the question and answer wants to discuss. But fully vaccinated means you've had whatever the series is, whether it's the 2-dose series from Moderna and Pfizer, or the single Johnson & Johnson dose, plus 14 days, and then you're considered fully vaccinated. The Johnson & Johnson vaccine, which had a little hiccup with some very rare but dangerous blood clotting complications in a very small subset of female patients, is now again being administered. That is a single dose vaccine. It does not use the mRNA platform, but it is what's called a viral vector vaccine, which means they use a commonly occurring virus, in this case, the chimpanzee adenovirus, or one of the viruses that causes common cold symptoms. And it uses that virus to introduce the spike protein information into the human body to again get the immune system to recognize the coronavirus without actually getting the coronavirus. So we currently have 3 vaccines. There are about 20 or so ongoing clinical trials for other vaccine products. There's still the Oxford AstraZeneca product, which is out there in Europe, but the complication rates seem to be even higher. And so it still remains to be seen whether or not that vaccine will make its way to the United States. We know that right now with the Pfizer vaccine, the minimum age is 16. With Moderna, it's 18. With Johnson & Johnson is also 18. However, they have now collected enough data, both Moderna and Pfizer, that they are getting their application together to modify their emergency use authorization to administer the vaccine to individuals aged 12 and up. And we anticipate that that will happen sometime as we move into the early summer. Studies that are ongoing are studies that involve children ages birth to age 12. And as that data gets collected, then that'll be compiled and added to the emergency use authorization application for a modified EUA. And that hopefully will happen before the beginning of the new school year so that all of our school-age children will have the opportunity to be vaccinated. There's some discussion now about what the booster schedule will be. And as the data continues to be collected, then we'll get more information about what our booster schedule will be. But it is widely believed that all of us will require booster immunizations at some interval in time. So really the purpose for why we're here this evening is to really talk about what COVID means to kids, because now again, we're seeing more kids who are getting COVID, many of whom are asymptomatic and finding out they're positive just because of a known exposure, started a process where they had to get tested, and some have some very mild symptoms. But there's a small subset of individuals of all ages, but in children as well, where they develop these symptoms that linger. And when you have symptoms that linger beyond 28 days, the term that the clinical realm is now using are called long haulers. And those are just simply individuals who, regardless of what their symptoms look like when they first got COVID, have symptoms that linger. These long haulers most commonly are complaining of fatigue and insomnia. That's by far the most common symptom. And this is not just your run-of-the-mill, I'm tired after a busy day of school or work tired. This is, I'm sleeping 18, 20, 22 hours out of the day. And when I wake up, I walk to go to the bathroom and I feel like I need to go back to sleep, and I go back to sleep for another 12 hours. So we're talking lots of fatigue. And sometimes, it's hard to tell, especially with our teenagers, what is normal teenage fatigue and what is this different level of fatigue. But fatigue is by far the most common symptom among long haulers that becomes quite debilitating. Kids that are not able to go to school, they're not able to stay awake in school, they're not able to finish their schoolwork. And right now, the data suggests that the number of long haulers is somewhere between 12 and 15%. And again, as the number of COVID cases increases, we're going to see more and more long haulers. And maybe that'll drive the percentages down or up. But right now, that means 1 out of 10 kids with COVID may experience these prolonged symptoms that last beyond 28 days. The other 2 areas which are of greater concern, especially for our children and teenagers that are participating in competitive sports or high intensity athletic activity, are the cardiac issues and the pulmonary or respiratory issues. So kids who've never been asthmatic, they've never had lung problems, they don't smoke, they don't vape, they can have some profound, long-lasting pulmonary symptoms that resemble asthma, that resemble what we call restrictive lung diseases as well. So these kids will complain of pleuritic chest pain, being winded with little exertion, uh, chronic cough, things that they did not normally have prior to contracting COVID. And then the cardiac complications, many children who are long haulers with cardiac complications will report chest pain, either with or without exertion. That is not reproducible, meaning when you press on the chest, it doesn't hurt, but it's just an ache that they can't quite pinpoint. They can't really explain. They also can complain of palpitations, fluttering in their heart or in their chest, a sensation of windedness, lightheadedness, dizziness with exertion. So if those are symptoms that your child or your teenager are reporting to you, or they've reported to someone else, then those are things that need to be further investigated. So I think with that, there's so much we can talk about with respect to kids, but I wanted to kind of put those 3 points out there: the numbers as we currently know them, the vaccines, and where we are as it relates to vaccinating children and teenagers, and what some of these complications are, and what that means for you as a parent as we move into the spring and summer, and our kids are going to be more active and outside of the school environment and in these less structured environments where they can congregate and gather and be around a lot of other people who are potentially not vaccinated. So if there are any questions, I'm happy to take questions now. And if not, I'm sure Betty has some questions that she can kind of generate for our discussion.
Yes. The question that we had come up that had come up here, one of the questions was if a teenager recently had COVID, what is the recommendation as far as how long they need to wait before they get vaccinated?
Okay. And that's a really good question because as the cases continue to go up, we're finding people who have tested positive for COVID, and then they get the phone call or the email or the text that says that, now their name, their whatever has come up in the queue and they're ready to be vaccinated. And so right now, the general recommendation is 14 days for individuals who've tested positive for COVID, perhaps longer if their symptoms are lingering, but a minimum of 10 days. And that's partly because we want the viral load to be less, and partly because if it's less than 10 days, then you're still not beyond your quarantine window. So we don't want you going to a vaccination site and infecting everybody in the gymnasium. So 10 to 14 days would be reasonable, provided that your symptoms are improving. And again, we don't consider loss of taste or smell to be a symptom that we monitor for improvement, because that can linger. But 10 to 14 days after the positive test, provided that the symptoms are improving, would be a reasonable time. And when you go to get vaccinated, they're going to ask you some screening questions similar to the questions that many of our young people get asked through an app or some other technology for school. And they're going to check your temperature to make sure you don't have a fever. And if you have a positive screening test or a positive series of screening questions, or you have a fever, then you will not get vaccinated. So I hope that answers that question. I will also say that in those long haulers, right now, the current recommendation is for children, for adults and children who are experiencing symptoms beyond 28 days. Before you get vaccinated, you should have a conversation with your primary care physician and weigh the risks versus the benefit. But there are no specific recommendations that individuals who meet that long hauler criteria, meaning symptoms that last more than 28 days, that they delay vaccination, because those individuals could have symptoms that last for 6 months. We don't believe that those individuals who are having these prolonged, persistent symptoms are infectious. We don't believe that they're shedding large amounts of virus, and therefore, from the standpoint of vaccination, there doesn't appear to be an increased risk to their health or safety if they get vaccinated. So, so if your child is still having symptoms beyond 28 days, talk with your pediatrician, your family physician, and have a conversation about whether or not the vaccine would be appropriate. The only other groups of individuals for whom the vaccination time frame is prolonged are for people who have had monoclonal antibody therapy or convalescent serum therapy as part of their diagnosis. And by definition, those individuals have moderate to severe symptoms. In order to qualify for monoclonal antibodies or convalescent serum, you cannot be in that mild group. So that excludes a large number of children. And I can't tell you how many children, if there are any, who have received monoclonal antibody therapy or convalescent serum for treatment for COVID in the United States. But for those individuals, the time frame is in 90 days. They are expected, or the recommendation is that they delay vaccination for 90 days. The last part to that question would be individuals who, in between the first and the second dose of the Pfizer or the Moderna vaccine, test positive for COVID. And the timing is such that it takes you beyond your 21 or your 28-day window for vaccination. So let's say you test positive on what would be day 17 after your first dose of Pfizer, and you're due for your second shot in 4 more days. Although it's very unlikely that you would get COVID, but let's say you do. So if you get COVID, you would now wait 10 to 14 days from the time that you tested positive, which takes you beyond your 21-day window. But right now, the recommendation is that individuals can continue in the current series of vaccine, meaning they don't have to start over, provided that they get the second shot within 21 days of the endpoint. So if it's the Pfizer vaccine, that means you actually have until day 42 to get your shot. And if it's the Moderna vaccine, it would be 28 days plus another 21 days. So you could go out to day 49 and still get your vaccine and not have to start over with the first dose.
Okay, we have another question here, but thank you for that, because I know that even my teenage kids' friends many are under the impression that if they've had COVID recently, they have to wait at least 90 days before they get vaccinated. So that, I think, is really a misconception that's out there. Here's a question. My teenager just had COVID and would like to travel this summer, but if a negative test is required to board the plane, he may still test positive for up to 90 days. Will an antibody test count? We will also check with the airline, but we thought you might know.
I think the answer is in the parentheses, is that I think it's going to depend largely on 2 factors. One, the airline itself and what their internal process and requirements are, and the jurisdiction to where you may be traveling and what their requirements are. It's very unlikely that 90 days out that you would test positive for COVID, but it's possible. And unfortunately, I don't think an antibody test would be considered validation of previous infection. At least our experience has been in helping individuals in our practice who are traveling. Many jurisdictions and consulates are not even acknowledging antibody testing. And I think it's just because it's not well known. The standardization is a lot tougher to monitor. I mean, it took a lot internationally for testing because there was so much variation in terms of the labs. And I mean, there were people who were creating their own documents, and so I don't imagine that antibody testing at any point is going to be used as a pass to get on a plane and enter into a country. So I would check with the airline, and then make sure you check with the consulate, because it would be a shame to get to a place, get off the plane, and not be able to get through customs because the airplane allowed you to get through with, say, a rapid test, but the country requires a PCR test. So you want to make sure before you travel.
Yeah, and in our experience, most most of the test requirements for any type of travel, a PCR test is usually what's needed. We have another question that says, my teenage grandson's fever began on Sunday, which fluctuates, highest being 103.8 and lowest 99. How long should the fever last? No aches or pains, just cough and fever.
So I'm assuming that they already know that that their grandson has COVID, because if they don't have if they haven't been tested for COVID, they certainly need to be tested for COVID. And if their test is negative, it could be that they are not shedding enough virus to be detected, although it's less likely now because the sensitivity for the test is so high, and you need very small amounts. I think it says tested positive. Good. So they tested positive, because I was going to say if they didn't, then they would need to be tested for flu and some other things, more typical childhood diseases. But if they tested positive, you can expect that fever. Viral illnesses can produce fevers that can linger for 7 days. They may get better with Tylenol or ibuprofen, Motrin, and then they spike back up. They can sometimes get higher at night. A lot of times you can tell that their temperature is up because they start to look sick again. The temperature comes down and they start looking normal and they're happy and they've got appetite and they're eating, they're drinking, they're playing, having fun, and then their temperature goes up and then they're just kind of laying there and they don't want to do anything. They don't want anyone to touch them. They don't want to eat. They don't want to drink. So I would just continue to treat the fever, depending on how old and how much the child weighs. That will determine how much Tylenol or Motrin they should get. If you have any questions, you should call the pediatrician or the family physician, because they can actually fine tune the treatment of with Tylenol or Motrin, because the bottle is going to give you some general information, but all pediatric doses are weight-based doses. And so sometimes we find that individuals are underdosed because the bottle doesn't account for their weight. And so that's why sometimes it's better to talk to the pediatrician. They can give you very specific recommendations that are weight-based. Because if, for example, you're underdosing a child by, say, 20 or 30% per dose, they may not even get to a point of circulating Tylenol in their body where they're reducing their fever at all. And all it required was an increase in dose to a weight-based amount. And then all of a sudden their fever comes down. But the fever could last a week or so. And it will go away.
Dr. Conti, when a teenager and any child has COVID, what are the concerns about them going back to their sport? How long do they have to wait before it's okay for them to start playing hockey again or playing soccer?
And that's a really good question. And I just want to follow up on the question from the chat about the 14-year-old grandson who's 145 pounds. So that's an adult dose. So they could take 650 milligrams of Tylenol or 600 milligrams of ibuprofen every 6 hours, as a weight appropriate dose for the fever. And again, if they need that again, they can connect with us offline and I can give them those doses again. But those are adult doses for those two medications based on that child's weight. So the concern with return to strenuous activity, or what the American Academy of Cardiology and a number of other entities can call high intensity aerobic activity. So again, if your child is not participating, say in American Legion baseball, but they are an avid recreational runner or rock climber or something for which there's no organized league they participate, they would still qualify as being participants of high intensity athletic activity. As well as a number of our patients and clients who are using our sports performance element of our practice and our office space to do personal training. That's high intensity. If you haven't been there, our Athletic Republic staff will definitely affirm that it's high intensity aerobic activity. So for those individuals, the recommendations are based on age and based on symptoms. So if you are under the age of 12 and you have had mild to moderate symptoms, uh, then uh, then your evaluation really can be virtual. And really the questions that should be asked during that virtual visit are: one, affirming that the symptoms are improving, confirming that uh, the child believes subjectively that they feel back to normal, and that objectively mom or dad or whoever is caring for that child believes them to be back to normal, and getting a sense of how long their symptoms lasted, if they had any symptoms at all. If they had symptoms that lasted for more than 3 days, then that visit should be in person. If it lasted for less than 3 days, it can still be virtual. But those questions are things like the chest pain, shortness of breath, palpitations, dizziness, lightheadedness, extreme fatigue. There are some, and this is all new territory. So there are no hard and fast screening recommendations. In our practice, we're trying to develop some screening recommendations based on what those symptoms are. So if someone comes to us to be evaluated, to return to high intensity athletic activity or sports physical activity, we're going to do a physical exam. We're going to do an EKG. We're then going to get resting vital signs, which include heart rate, pulse, and pulse ox, or oxygen level in the blood, the little thing that you stick on the finger and it gives you the reading. And then we're going to have them go over to our Athletic Republic space and spend a little bit of time on a treadmill. And then we're going to repeat their vital signs, their heart rate, their blood pressure, their respiratory rate, and their oxygen saturation afterwards, and ask them how they feel. And so, again, it seems a bit overkill. However, uh, you know, a lot of times, especially with children and teenagers, they can be very stoic about what symptoms they're experiencing. We may find that a child is saying they're feeling fine. Mom and dad believe they're doing fine, but they've been convalescing at home for 14 days. And then we see them in the office and their resting heart rate's 120 and their pulse ox, their oxygen level is 89%. But because they were at rest at home, just kind of convalescing, no one really knew. But those are abnormal vital signs. So again, if the symptoms lasted longer than 3 days, then that visit should be in person. Someone should physically put their hands on that child, that teenager, and examine them. Maybe not as extensively as what we just talked about, what we're planning to do, but at least a physical face-to-face examination. If you're over the age of 12 and your symptoms last longer than 3 days, then you absolutely need an in-person exam. I'm recommending in athletes over 12 that they all have a face-to-face exam with their pediatrician, family physician, and that includes a cardiac exam, a lung exam, and at least resting vital signs. Because a lot of times you will find clues to someone's illness just by looking at their vital signs. That's why we call them vital signs. They're very, very sensitive indicators many times of underlying conditions that appear to be normal when you just look at a person and don't assess them. If your symptoms required hospitalization for any amount of time, then by definition, that is moderate to severe disease. And those individuals, the current recommendation is that none of them should return to active, high intensity sports or athletic participation without both a face-to-face exam with a pediatrician or primary care doctor, as well as a cardiac evaluation from a cardiologist. And that again is because of the likelihood of, or the increased risk of cardiac and pulmonary complications. And with respect to those face-to-face exams, if a face-to-face exam yields an abnormal finding, say a murmur that a child never had, a heart rate that appears to now be irregular, an EKG that is abnormal, then that would prompt the physician to not clear that person. Again, any clearance from the doctor is not going to stop a parent from allowing their child to participate if they want to, because I can't imagine very many, if any, local sports organized entities that are going to go into the realm of medicine and start saying we're requiring medical clearance for kids who had COVID. But the point is that at least now you're making an informed decision. And if the information is suggesting that there's something perhaps abnormal, then the recommendation from the primary care source is going to be that that child needs further evaluation from either a cardiologist, perhaps a pulmonologist, maybe an endocrinologist if it's a more of a fatigue kind of an issue. But again, we're not trying to keep kids from playing sports. That's not what this is about. And again, the likelihood is still very low. I don't want people thinking that all these kids are now at risk. However, one of the things that organized sports has become in America with youth sports is it's become not only ultra intense, but it's become never ending. There's no end point. These professional athletes get 6-7 months where they're not playing competitively. They may still work out, they still may have a personal trainer, and they may still work on their craft, but the season ends. But with youth sports, they play rec league, then they play tournament, then they play American Legion, and then they play All-Star. And so for out of 365 days, they're probably playing their sport at a competitive high level 330 days. So we've made it very intense on top of just the competitiveness of it. So, in my mind, I would want the peace of mind to know at the very least that if my child had COVID and the cardiologists and the sports medicine doctors and the pediatricians are saying that, hey, this is worthy of an evaluation, then I would probably want to get my child evaluated after COVID, at the very least to give me that I can sleep at night knowing I did my due diligence. Have we had any COVID related complications that I'm aware of in the state or in the county? None that I'm aware of. And I don't know what this next round of sports physicals is going to look like. But I know that, with concussion, they added a whole page to the sports physical packet of paperwork. With sudden cardiac death, they added a whole page to it just says you as a parent, you're signing off saying you understand that strenuous activity can result in sudden cardiac death and you're not holding anyone responsible and you're knowingly signing that document. I would imagine that within the next year or two, there will probably be some kind of a COVID signature space on these physical forms because COVID is becoming so prevalent among kids. I hope that answered the question. And again, if anyone has any kind of questions offline, I'm happy to answer those too.
Let me just ask you, so if somebody does call their pediatrician office and say, I want to have my, child come in for a post-COVID evaluation, and they say, I don't know what you're talking about, they can always call Connected Health for that.
Correct. They can call us and we're happy to do the evaluation, or at the very least, we can tell you what questions to ask of the pediatrician and to give you a kind of a layer of empowerment for that conversation to say, well, I was reading or I attended a Zoom where they had referenced the current recommendations for returning to sports after COVID, and they recommended an evaluation by a pediatrician or a family physician prior to returning to participation. And it still may not be something with which they're familiar, but at least now, if they still are reluctant to want to do the exam, then you can find other venues where that exam can get done.
Okay, we have a couple more questions. One that says, thank you for the presentation tonight. Should we hesitate sending our kids to overnight camp this summer? That's a good question.
That's a really good question too. Especially after, last spring, there was a whole little news cycle where they talked about this super spreader event at a camp in Georgia, I think it was. So a large number of those kids, especially any kid at an overnight camp under the age of 16 is not going to be vaccinated. I would do your due diligence and vet the camp. So number one, I would want to see what the safety procedures are in place, how many kids are staying in the cabin? Is the cabin well ventilated? Are kids required to wear masks? What is their contingency plan for physical distancing during meals and during times of the day? And then I would also inquire about, what are you doing about testing, interval testing, while the child is in camp? Are they doing testing? How are they screening the children every day? Those are questions. And if those questions are answered to your satisfaction, then there's always inherent risk with COVID or pink eye or strep or mono. And you have to then, as a parent, make the very best decision for your child that you can make. But asking those questions at least gives you a level of informed decision making. And if they can't answer those questions to your satisfaction, or it appears that those questions haven't even been considered, then you might want to consider a different camp option for your child. I'm not telling you to not send your kid to camp. I know my daughter's going to camp. So, and she's excited because she missed camp last year, and she went to camp for the very first time in 2019, and she was bummed out all summer because she couldn't go. But I would say that I asked those questions of her camp, and was very pleased at the answers. They're going to test the kids that are going to be there for 2 weeks. They're going to test them mid-cycle, and you have to come in with a negative test. They're testing all the counselors before they arrive and mid-cycle, and they're screening them every day. They've cut the number of kids in each cabin in half. So they're doing all the right things that I feel, comfortable enough allowing her to go to camp.
Okay, this is our last question. It is, my college freshman tested positive on the 23rd. Symptoms starting on the 18th, 19th. Wants to come home from isolation this weekend, doesn't have any symptoms. With over 7 to 10 days since his first symptoms, is he safe to come into our house, or is he still contagious? His siblings and parents don't have their second vaccine shots yet.
Man, that's a great question. So, and the dates are critical, because if he was symptomatic on, let's just say, the 19th instead of the 18th, then his quarantine period, even though he didn't test positive until the 23rd, would be 10 days from the 19th, as opposed to 10 days from the 23rd. So his quarantine period actually ends today. And so as long as his symptoms are improving and he's fever free, he does not need to retest. He doesn't need to quarantine, nor do people need to be separated from him. Add to that the fact that all of the other people in that house are at least partially vaccinated, which means they also have some immune response. I think he's perfectly safe to come home. He should not get vaccinated again for 10 to 14 days from the day he tested positive. So the delay in vaccinations from the time he tested, not from the time he developed symptoms. But if for some reason he finds it difficult to get a vaccine, we still believe that individuals who have disease-associated immunity, that immunity lasts for 90 days. So that means that if let's say he can't get vaccinated for whatever reason for another 3 months, but he's now has disease confirmation with a test, and he has now disease-mediated immunity, or immune response. So he doesn't need an antibody test to prove it. But what the recommendations currently say is that he does not need to retest or re-quarantine if he is exposed to someone else with COVID during this 90-day window, unless he himself develops symptoms after that exposure. So let's say on June 1st, he gets exposed to 3 people at a cookout who test positive for COVID, but he remains symptom-free and he still hasn't been vaccinated. He doesn't need to re-quarantine. He doesn't need to retest unless he starts to develop symptoms. I hope that makes sense. Beyond that 90-day window, and hopefully by then he will have finished his vaccine series, but if he didn't, beyond that 90-day window, if he were exposed at that point, like say September, then it would be as if he didn't have COVID and he would be expected to re-quarantine and retest.
Only because you brought it up, what is your opinion about the antibody tests?
So I think, I think the antibody testing accuracy and sensitivity is getting better. We now have both antibody tests that are sent to the lab, to an outside lab, and many entities now have the capability of doing rapid antibody testing, which takes about 15 to 20 minutes to result. So from the standpoint of giving you personal information about your immune status, it can give you some valid information. But if, for example, you tested positive for COVID 150 days ago and your antibodies are negative, I mean, I don't know that that tells you anything more different than what the recommendations would say anyway. It just affirms that you still need to be vaccinated. So if you're looking to use disease-mediated immunity as an out for getting vaccinated, you still should get vaccinated. That is the clear recommendation, is that people who have had COVID should get vaccinated. So, I don't think that antibody testing is going to be used widely as a means or a substitute for testing or for vaccination, meaning I don't think that you're going to be able to use a piece of paper that gives you that attests to your antibody status to travel or to attend something that requires a test as verification or a vaccination card as proof. So I don't know that that's ever going to happen, but it might. So really the antibody testing is really more for just your personal knowledge and information.
Thank you, Dr. Conti. That was really, really interesting. No matter how often I hear you answer these questions, I'm always still super interested in your thoughts and your opinions on all of this. If anybody that is participating in this event would like more information, feel free just to call us. Make sure you like us on Facebook. It should have our phone number and probably an email address too. And then if anybody has questions, you can always just shoot an email over to info@connectedhealthpgh.com. We'll make sure that it gets to Dr. Conti or whomever. So thank you everybody for participating, and we'll look forward to hearing more in the near future.
I'm sorry, if I could just say one more thing, just because I get some emails on the soccer side here locally, because especially if your child is playing a sport in a travel league where you're going to different counties, where you're going to different towns. One of the things that I'm finding is that the organized soccer body for Western Pennsylvania has not lifted the mask mandate for participation in sports for youth because the governor hasn't lifted the mask mandate. And we're getting a lot of questions because our teams locally are traveling to other places in Pennsylvania where neither the officials in that league, the referees, or the parents or the players on the other team are wearing their masks. So, and the only advice I could give you is that if you feel no different than if the field looks unplayable or if the coach is acting ridiculous, if you feel unsafe with your child participating, either because they have to wear the mask and you're concerned about how it's going to affect their breathing, or because you see the fans on the other side of the field, the coach and the players on the other team not wearing masks, then you do right by your child and you do the right thing. You let your coach know, I don't feel comfortable in this space. And if they can't rectify it, which sometimes is difficult, then I would not hesitate to put my kid in the car and go back home. And I put that out there just because as more and more kids are now playing sports and traveling, you're going to run into these various dilemmas where you may be very conscious of distancing and masking and all of these things, but you're going to be going into places where that sentiment isn't shared. And then you're going to have to make a decision, which may not be popular with your coach or your child. But again, the numbers tell us that the number of COVID cases in kids and teenagers is skyrocketing. It is alarmingly high, to the extent that Allegheny County is very alarmed by the numbers, not because these kids are getting super sick, but just because the numbers are going up so fast. And you know, with more cases comes more likelihood for hospitalization and all those bad things. So I put that out there because that's going to be a very real-time dilemma that parents may face even tonight. If you're still having practice despite the rain, or you've got a game coming up on Saturday, this may be a very real scenario for you. And I just want you to feel comfortable knowing that, hey, if you're doing what you feel is right, then you can't, no one could fault you, and no league, no coach, no player, no opponent should shame you or your child because of those decisions. And if you get to that point, then that tells you that maybe that's a league you don't want to play in.
Thank you so much, Dr. Conti. Really, really good information. If anybody wants to get in touch with us, you can always send us an email at info@connectedhealthpgh.com. Like us on Facebook, send us a message, and we'll look forward to doing another one of these in the very near future when you have more to update us on. So thank you, everybody. Have a good night.
Good night, everybody.